Welcome to the World Diabetes Congress from IDF 2025 here in Bangkok, Thailand. My name is Ronaldo Pineda Wieselberg. I'm an endocrinologist and president of ADJ Diabetes Brazil, and I will be the co-chair of this session with Professor Jaco Abodo, professor of endocrinology, immediate past chair of African region for IDF, and elected as vice president physician for IDF. Professor Jaco, it's with you.
Thank you. Good morning, everybody. We are going to start. We have 3 speakers this morning. The first is Stéphane Besançon. Stéphane Besançon is a professor of nutrition and global health and is sitting in Mali, Bamako. He's the president of NGO Santé Diabetes Mali. He works very well in NCDs and is associated to program of African training in endocrinology and diabetology and nutrition. He's going to speak about diabetes education and prevention in low and middle income countries. Example of Mali. Professor Stéphane Besançon, you have the floor.
Thank you. Thank you very much, and thank you to invite me to do this presentation. And I will start. We'll try in 20 minutes to give you our experience of both sides, education of patients, but also prevention using peer education in Mali, but also in other countries in Africa. So I have nothing to declare. I will cross this presentation about 3 parts. The first one is the development of the methodology, because us to use peer education is also a question of methodology to select, to train, and to follow the peer educator. And after, I will give you 2 examples of 2 research protocols, one of education of patients and one of prevention of persons of risk of diabetes, and the result of the 2 protocols to try to evaluate if that's work or not, and the final part will be the conclusion. So I will start with very central part on the work of peer educator is the question of it's okay, sorry. To select and train the peer educator before the action. Just some words for you, because I will do my presentation about Mali. Mali is a West African country in yellow on the map. It's one of the poorest countries in the world. Diabetes prevalence in the last diabetes atlas is 1.8%, and the hypertension prevalence is around 20%. And this slide is very, very important for the rest of the presentation. Is when we started to work in Mali in 2004, it was one country with the lowest in health globally, a limited access to general health service, and an extremely limited access to important for the rest of my presentation and to understand why we decide to work with peer educator. In this, in very little bit side setup, we start to work to try to develop diabetes care in the capital and outside in the capital with a strong methodology. We train people, we give access to treatment, we work on access to HbA1c and other laboratory tests, and step by step, we set up 35 diabetes consultation around the country. It's not the topic of my presentation today, but you can find all this work done with a lot of partners, and David Barron, who is here, to understand what we do and how we strengthen the health system. But it's this work also is a starting point of my presentation on why we use per educators, because we give a strong access to care for 35,000 patients, but there was a strong challenges because a lot of patients, a small quantity of human resources in the health system, and we had a very strong to develop diabetes education and diabetes prevention. So if it's a situation, with this situation, we decide to try to overcome this shortage of human resources and to develop prevention and education using peer educator to give more resources, various healthcare resources and other resources to try to develop the system around the consultation. And for us, the idea at the beginning of this reflection and this work, it was three benefits. We imagine one, to reduce the challenge of the limited access to human resources. The second one is the capacity to provide longer and more intensive prevention or educational session. And it was also to involve the capacity with this peer educator to involve patient organization in the process. And it's I want to focus on this slide before testing this with protocol, research protocol. We work almost 2 years to develop a strong methodology in different steps on the recruitment, initial training, testing, and the longitudinal monitoring of peer educator. Because we use peer educator from the community. It's a volunteer, just with small incentive for the displacement. So for us, it was very, very important to focus on the recruitment. So we developed a specific sheet of recruitment with specific criteria, including the community leadership, communication skill, availability, because we are speaking about volunteer, and the age also, and the role in the community. The second, that was one point to try to define the better criteria for the recruitment. The second thing, we work a lot around the initial training, who was focused on the role of peer education, the health communication, and after, depends the tools of what you used, the training around the tools of prevention or education. The first step, also very important for us, is to test, not just to have theoretical training, but also after to have training in practice with the community, and to keep at the final the peer educator who have a good theoretical level, but also demonstrate the capacity in the community to communicate, to transfer the message, etc., etc. And the last step of this methodology is not to finalize the training and put the peer educator in the community to do, but also to organize a longitudinal monitoring to be sure that the message is good, the communication is good, and there is a real impact and viral role in the community. So we work a lot on this methodology, and when it was not over, but we think it was validated, we decided to test it through 2 different research protocols. The first one, we started 10 years ago with a protocol around the therapeutic education of patients, so to strengthen this therapeutic education for people living with diabetes using the peer educator. So the main objective of this protocol was to compare the improvement in HbA1c 1 year after a 12 months of education intervention led by the peer educators alongside conventional care versus the standard care alone. And we measure 2 things, the intermediate change in HbA1c at 3 months, 6 months, and 12 months. And we compare the evolution also of biochemical parameters, the weight, BMI, blood pressure, waist measurement, also at 3, 6, and 12 months. We recruit 150 persons living with type 2 diabetes in the capital of Mali, Bamako. Before starting the training, we also we use a tool of education used in France and in different countries. The name of the tool is Learning List methodology, but we did a 6 months of strong work to adapt the tools to the local context. So the adaptation is with the picture, but also the context on the diet, for example, to be adapted to the local context, but also on the language. So there is a strong work of adaptation of the tools to be sure that it's adapted to the Malian context. And we adapt 4 booklets: managing cardiovascular risk, managing physical activity, managing fat in the diet, and managing insulin treatment. And we use after, during the session, these 4 booklets. So I don't come back on the methodology. We use the methodology present previously to train the periodicator around also this methodology. We randomize in 2 groups, 75 and 75 patients. One group without specific education, just the control group with the classic consultation, and a specific education group provided by the periodicator. It was an intervention group. And the patient receive in focus group for 10 a complete education cycle using the 4 booklets. And we use 5 patient educators who conduct 177 animation sessions to complete all the 4 cycles of education using the 4 booklets. And we check the randomization to be sure that in the 2 groups we have no specific difference, and you can see on the different parameter between the control group and intervention group at the integration. We have 76 patients in the intervention group and 75 in the control group, and there is no significant difference between the 2 groups. So we had a global validation of the 2 groups to continue the protocol. And the periodicator lead the 1 year of activity. We measure all parameters during this year, and at 12 months, that is very interesting because you can see on this slide there was a 3 positive difference in the the BMI, in the waist circumference, and also in the HbA1c between the control group and the intervention group due to the intervention by the periodicator. So we demonstrate with this protocol we have a very positive effect on 3 parameters: the BMI, the waist circumference, and the HbA1c of the patient educated by the peer educators. And this is really the effect of the education by peer educators, because it was at this time in Mali, it was the only one education, very strong education available for the patient. If you want more on this protocol and the result, the global result, we publish all this result in +1. I let you take, if you want, the reference, and you can see all the protocol deeper with all the results, all the methodologies that we use on this protocol. And now we validate the methodology, we validate the concept with this publication and this result, and we extend the work with peer educator on education of patients in Mali, in Burkina Faso, in Comoro, in our different countries we're working, and we extend also geographically because we start uniquely in the capital, and now we extend also in different regions with some complication, because if you want to follow the peer educator in different parts of the country, it's not simple, but it's a very useful tool to strengthen the education of patients when the context is with very, very limited resources. So with this result on education, so we validated and we go operationally almost in all countries we are working. we decided to try also to use pre-education, but not for education of patients, but for prevention of people with risk factor of diabetes, and to test, is it the same result or not? Is it in interest also to use pre-educator on prevention and not just on education of patients? And so we decided to try to test the improvement of diabetes risk factor prevention among people living with HIV with high risk factor of diabetes, also using peer educators. So this second study, the main objective was to evaluate the impact of the prevention, the action of prevention on diabetes risk factor among these people living with HIV using also animation with other tools conducted by the peer educator, and we try it to change the context and to see also the replication in another context in Burkina Faso and Comoro. And the secondary objective was to analyze the variation in health education outcome using the health education impact questionnaire, so a questionnaire of health literacy developed by the Dakin University and Professor Richard Osborne, with a baseline and follow-up for with patients. And we're using the same questionnaire also to analyze the changes in physical activity level, awareness of weight, and awareness on alcohol and tobacco consumption. If you don't know the HIQ, it's multidimensional tools with solid psychometric properties. It's a huge questionnaire, or if you want to use it, it's a huge work with patients of our population, because it's a strong questionnaire with 40 items, cover 8 dimensions, 4 items for the health practices, 5 items for active and positive engagement in life, 6 items of self-care and involvement in care, 5 items on constructive approaches and attitude, 4 items on technical acquisition and skill, 5 items on social integration and support around health and around the condition, 5 items around navigating in the health system or the global system for prevention, and 6 items on emotional impact. And each item is rated on a Likert scale with different degrees. You can see on the slide, 1 is strongly disagree, and to 4 it's strongly agree. And for the global analysis, 8 dimensions represent independent scale with score calculated by averaging 4 or 6 items with each dimension. Previously, this questionnaire was developed in Australia, so we did a strong work to adapt it, to validate it. There was a publication on the validation, on the concept, but also on the language, to be sure that it will be totally adapted in the local context. So we developed a specific tools with the support of different our partners on this question of diabetes, HIV risk factor. Tools we will be used by the peer educators. We involve 117 participants in a specialist consultation on HIV, person with high risk factor of diabetes. And we start the educational intervention with the peer education. We trained 34 peer education, and they did the education prevention session during 6 months, and we assess the baseline with the questionnaire and the follow-up during a 6-month period. And you can see the result here. There was very significant impact on this prevention program with different improvement. We did not improve every parameter. You see the different scale available. So in Comoro, we have a significant improvement of active engagement around the health and our life, the self-care and the measure around the self-care and the prevention, and also all the dimension or all the social integration and the positive effect to participate to this type of activity in the community with peer educator. In Burkina Faso, it was a little bit different. We have positive effect on self-care, social integration, and constructive attitude and the change of practice. We have in Burkina Faso an increase significantly on the attitude of prevention around the weight, not in Comoro. We have in both countries strong increase of practice of physical activity and engagement around the physical activity, and the consumption of alcohol stays stable, but the smoking decrease in 2 countries, and it's a significant result. So this work is in progress of publication, but we will have a poster tomorrow. Don't remember the time, I think around 12. Our colleague from the University of Burkina Faso, Nakabo Rolande, will present it, and it is the first step to go to the publication. And another time, like with education, we demonstrate that it's possible to use periodic exercise for prevention and to obtain result and scientific result, validate, to go and to continue to extend this network of peer education and to develop 2 different networks of peer educator, one network for patient, for education, or on diabetes, and one on prevention on the risk factor. The conclusion of all this work, it's almost 10 years of work, it's that this research, 2 research, demonstrates a very positive result using peer educator in a context with the resources that's very low to obtain good result in prevention and in therapeutic education. But to achieve this result, it is essential to develop a specific methodology. It was a very strong work around the methodology for recruiting, selecting, and training peer educator to be sure to obtain the result. That's its very key point. And to create also prevention and education tools really adapt to the local context, not just to copy tools to other countries. That it's also a key point, a strong methodology for the recruitment and training of peer educator, and a very, very focused population and local context of the tools. And also the very strong importance of implement a rigorous monitoring to ensure the quality of activity conducted by the peer educators. Thank you.